हे गाइस, स्वागत करता हूं मैं आपको अपने YouTube चैनल में जिसका नाम है medico। और आज हम लोग डिस्कस करेंगे लंग्स की कैपेसिटीज के बारे में। उसके बाद इसके आगे हम लोग डिस्कस करेंगे अलग अलग तरह के ब्रीथिंग पैटर्न्स और रेस्पिरेटरी रेट्स और दूसरे बहुत सारी चीज़ों के बारे में हम लोग चर्चा करेंगे इस लेक्चर में। तो वीडियो एंड तक देखिएगा, बहुत इंटरेस्टिंग रहने वाला है और बहुत कुछ आप लोग सीख सकते हैं। तो शुरुआत करते हैं हम लोग बेसिक लंग कैपेसिटी से। इसका जानना हमें बहुत ज़रूरी है, उसके बाद ही हम लोग एडवांस चीज़ों की तरफ जा सकते हैं। ठीक है, तो इनिशियली कहाँ से शुरू करते हैं हम लोग। ये एक स्पायरोमेट्री का ग्राफ है। ठीक है, एक स्पायरोमेट्री का ग्राफ है। तो इस ग्राफ में हम लोग को क्या देखने को मिल रहा है, तो मैंने यहाँ पे कुछ चीज़ें लिख रखी जैसे कि टीवी, IRV, ERV, RV, VC एंड टोटल लंग कैपेसिटी। इसमें क्या होता है कि अगर हम लोग इस ग्राफ को एनालाइज करें तो इस दो लाइंस के बीच में जो भी है ये दूसरे दूसरे तरह के लंग वॉल्यूम्स को बताता है जब हम लोग एक स्पायरोमेट्री ग्राफ को रीड करते हैं। ठीक है, तो टोटल लंग कैपेसिटी क्या होता है कि हम लोग के लंग्स में टोटली कितना एयर रह सकता है। ठीक है, तो उसका वैल्यू अराउंड 5800 मिलीलीटर्स आता है इन हेल्दी अडल्ट। एक हेल्दी अडल्ट में 5800 लीटर्स का टाइडल टोटल लंग कैपेसिटी हम लोग को देखने को मिल सकता है। इसका फॉर्मूला मैं बाद में बताऊंगा आप लोग को। तो नेक्स्ट हम लोग इससे क्या देख सकते हैं कि इस दो लाइन के बीच में जो स्पेस है इसको हम लोग क्या बोलते हैं, टाइडल वॉल्यूम। टाइडल वॉल्यूम क्या होता है, तो उसका डेफिनेशन इज वॉल्यूम ऑफ एयर एंटरिंग एंड लीविंग लंग्स ड्यूरिंग अ सिंगल ब्रीथ। तो एक सांस में हम लोग कितना हवा अंदर ले सकते हैं और बाहर छोड़ सकते हैं, तो उसको हम लोग टाइडल वॉल्यूम बोलते हैं और उसका वैल्यू 500 मिलीलीटर होता है, 500 ml। अगला क्या देखने को हम लोग को मिल रहा है, वाइटल कैपेसिटी, जो इस ब्लू लाइन से इस ब्लू लाइन तक है। ठीक है, तो वाइटल कैपेसिटी क्या होता है, तो वाइटल कैपेसिटी क्या होता है इधर, तो इंस्पिरेटरी रिजर्व वॉल्यूम प्लस एक्सपिरेटरी रिजर्व वॉल्यूम प्लस वाइटल कैपेसिटी। सो इंस्पिरेटरी रिजर्व वॉल्यूम क्या होता है, एक्स्ट्रा वॉल्यूम ऑफ एयर दैट कैन बी मैक्सिमली इंस्पायर्ड ओवर एंड अबव टाइडल वॉल्यूम। सो हम लोग के लंग में ऑलरेडी 500 ml एयर प्रेजेंट है, उसके अलावा हम लोग कितना और सांस अंदर ले सकते हैं, तो उसको हम लोग इंस्पिरेटरी रिजर्व वॉल्यूम बोलते हैं। ठीक है, तो दैट इज 3000 ml उसका आता है। ठीक है, नेक्स्ट इज एक्सपिरेटरी रिजर्व वॉल्यूम। सो डेफिनेशन क्या बोलता है, एक्स्ट्रा वॉल्यूम ऑफ एयर दैट कैन बी actively expired by maximum contraction beyond normal volume of air after resting tidal volume। so क्या बोलते हैं, जब हम लोगों ने मैक्सिमम एयर हम लोगों ने नॉर्मल इंस्पिरेशन कर दिया है तो हम लोग के लंग्स में थोड़ा हवा बच जाता है विच इज टाइडल वॉल्यूम 500 ml। उसके बाद जो भी एक्स्ट्रा एयर हम लोग निकाल सकते हैं उसको हम लोग क्या बोलते हैं, एक्सपिरेटरी रिजर्व वॉल्यूम विच इज 1000 मिलीलीटर्स। नेक्स्ट क्या हम लोग देख सकते हैं यहाँ पे, आरवी। आरवी क्या होता है, रेसिडुअल वॉल्यूम। सो मिनिमम वॉल्यूम ऑफ एयर रिमेनिंग इन लंग्स इवन आफ्टर फोर्सफुल एक्सपिरेशन। तो जो कम से कम हवा जो लंग्स में रह जाता है चाहे हम लोग कितना भी छोड़ ले। सो इसका इम्पोर्टेंस क्या है, सो अगर लंग्स से सारा हवा निकल गया तो लंग्स विल कोलैप्स, लंग्स कोलैप्स कर जाएगा ड्यू टू प्रोमिनेंट फ्रिक्शन। फ्रिक्शन रहेगा उस सबके बीच में, इसीलिए लंग्स कोलैप्स कर जाएगा। इसीलिए हम लोग के लंग्स में रेसिडुअल वॉल्यूम रहना जरूरी है, राइट, इसीलिए रेसिडुअल वॉल्यूम रहता है। नेक्स्ट क्या है, तो हम लोग ने सब कुछ डिस्कस कर लिया, तो इसके वैल्यू देखते हैं। टाइडल वॉल्यूम 500 ml, इंस्पिरेटरी रिजर्व वॉल्यूम 3000 ml, इंस्पिरेटरी कैपेसिटी IC 3500 ml विच इज इंस्पिरेटरी रिजर्व वॉल्यूम प्लस टाइडल वॉल्यूम, इसलिए 3000 प्लस 3500। एक्सपिरेटरी रिजर्व वॉल्यूम इज 1000 ml एंड रेसिडुअल वॉल्यूम जो 1200 ml 1200 ml। सो कुछ इंपॉर्टेंट फॉर्मूलाज है फ्रॉम द एग्जाम पॉइंट ऑफ व्यू। सो इंस्पिरेटरी कैपेसिटी राइट IC which is tidal volume plus inspiratory reserve volume, value 3500 ml। functional residual capacity, expiratory reserve volume plus residual volume, value is 2300। vital capacity, that is vital capacity plus inspiratory reserve volume plus expiratory reserve volume, the value is 4600। total lung capacity, टोटल लंग में कितना एयर रह सकते हैं, इंस्पिरेटरी रिजर्व वॉल्यूम प्लस टाइडल वॉल्यूम प्लस एक्सपिरेटरी रिजर्व वॉल्यूम प्लस रेसिडुअल वॉल्यूम, वैल्यू इज 5800। इसके बाद हम लोग डिस्कस करेंगे वेरियस रेस्पिरेशन पैटर्न्स एंड हाउ आर द रेस्पिरेटरी पैटर्न्स इंपॉर्टेंट टू अस। Discuss about breathing patterns. So what are breathing patterns? They are basically different types of breathing observed in people either with a pathological condition or in general conditions. So there are many types of breathing patterns such as tachypnea, apnea, bradypnea, then biot respiration, chain stroke respiration, small respiration. So these are various types of respiration patterns or breathing patterns which we can record on the spirometry, right? So we will try to understand in a simple way how this respiration pattern works and what is it all about. So starting from this, the breathing pattern. So there are mainly two types. One is the thoracic and one is an abdominal. So thoracic, it is also known as the coastal breathing, whereas the abdominal is also called as a diaphragmatic breathing, which is more prevalent in males, right? The diaphragmatic breathing is more prevalent in males, whereas the thoracic is seen more of in females. So obviously from the name itself we can understand that here the thorax is being involved, right? The thorax is being involved. So what happens over here is it's mainly by the intercostal muscles. So at the time of inspiration, what happens? The intercostal muscles contract and elevate the ribs. So the ribs get elevated, they move outward, right? And the thoracic cage is expanding. So the thoracic cage is expanding. Now the lungs can expand. So gas can fill inside, lungs can expand, and breathing can take place. And similarly, the opposite happens. That is, the relaxation of intercostal muscle will take place, due to which the thoracic cage will again contract and the space inside becomes less, and hence expiration takes place. So this is simple thoracic or costal respiration. This is seen in women, right? Next is the abdominal diaphragmatic breathing. So here what happens is mainly the diaphragm is involved, right? The main muscle over here is the diaphragm. It is located below the lungs, right? So what happens here is in inspiration, what happens? The diaphragm contracts, descends into the chest, right? It's moving into the chest, and it increases the thoracic capacity, right? The thoracic capacity is increased now, right? The enlarged thoracic capacity, thoracic cavity decreases the intrathoracic pressure. So what happens is anything in this universe has a tendency to move from an area of high capacity to low capacity, right? From wherever it is present in excess to in a lower place, right? If you put water in a place, it will start to flow, right? Because if here it's excess, it moves towards the place where there is less of water. Similarly, we have osmosis also, we have diffusion also. Here the concept of diffusion is taking place. So what is happening is there is low pressure inside and the atmosphere has a very high pressure. So what happens is air will rush in from high pressure to a low pressure area. So in abdominal breathing, what is happening? Basically a low pressure is being created so that from high pressure the air can move in, right? So the air is moved in, air rushes through the tracheobronchial tree into the alveoli and expands the lungs, right? And pushes the abdomen content, abdominal walls outward. So what happens? The content of the abdomen goes outward and even the abdominal wall is also moving outward. So this is what is happening, and then as we know, due to the elastic nature of the lungs will contract back again and the air is moving out, right? So this is how abdominal respiration works, and this is seen in males. Then there is mixed type of respiration. So this is generally seen in older people, and also most of the times if it is present in younger people, it is always pathological, it is not physiological. So it involves diaphragm and costa at the same time. That is why it's called mixed, right? Seen in old people and some pulmonary and GI pathology. So what happens in females, in case of dry pleura, pleural adhesion, myositis, thoracic radiculitis, and lung emphysema. So anything which relates to the swelling of this area, right? If this area there is a swelling present, right, inflammation or some emphysema is present, then we can see it in females because it is affecting the coastal area, right? So the diaphragm also gets involved. Next is in males, what happens is underdeveloped diaphragm. If the diaphragm is not developed completely, diaphragmitis or the inflammation of the diaphragm, acute cholecystitis or bile stones, right, and perforating ulcers if the ulcers are present. So it is related with the GI pathology and the pathology of the lungs, right? So in these cases we can see mixed respiration. Now let's come to the concept of RR or respiratory rate, right? Respiratory rate, the number of times inspiration and expiration takes place, right, in a minute. So one inspiration and one expiration is considered one, right? A cycle basically. So what happens here is how do we count it, right? We count the movement of chest or abdominal wall when the patient is unaware of it. So we basically count the inspiration and expiration, because if the patient is aware of it and you're counting, then you tend to see that you will take one breath and leave it out with the doctor's count. So it is done when the patient is unaware. So what happens in adults, it is 16 to 20 per minute, and inspiration is for 2 seconds and expiration is for 3 seconds, so a total of 5 seconds, right? And in case of newborn, what happens is 40 to 45 breaths per minute takes place in newborn, because their lung capacity is small, so they have to breathe for more. With age, this comes down, and in night, what happens is 12 to 14. In night, for young children, it goes to 12 to 14, and also after having a heavy meal. But in case of any physical exercise, again it will go up, right? It's all normal. So now we will discuss about the types of breathing patterns. So first of them is tachypnea. Tachypnea is similar to tachycardia. Like in tachycardia, we have fast heart rate. So here it is fast breathing rate. So respiration rate is above 20 per minute, right? RR is above 20 per minute. So if we see the spirometry reading, if this is normal breathing, right? So each of this suppose is inspiration, and this suppose is expiration, right? Each crest is indicating a inspiration and expiration. The trough over here of the wave is representing the end of the respiration cycle, right? So that's how it's indicated. So this is a normal breathing rate, right? But in tachypnea, if you see, it is like a sawtooth, right? A sawtooth. So it is very rapid and the breathing is very shallow. It's something like when you run and then you start breathing very fast, right? Your breath is very shallow. Like you're not taking a deep breath, you're taking a very shallow breath, but then you're breathing very fast, like multiple times, right? So what could be the pathological? See, if running is the physiological cause, right? What could be the pathological cause of this? So conditions associated with decreased lung surface area. So if the surface area of the lung has decreased, right? If there's more surface area, more gas can enter. If there is less surface area, then definitely less gas can enter. So your breathing gets shallow, and you have to breathe multiple times. So emphysema and edema, pulmonary edema, yes, emphysema and pulmonary edema both refers to the swelling of the lungs. Inflammation, again, don't confuse inflammation and edema. They are two different things, right? Inflammation and edema are two different things. This is mostly associated with allergic reactions, right? Which is associated with mast cells and immunoglobulin, whereas edema is where the protein content in the blood is lost, right? When the protein content in the blood is lost and the intratissue fluid moves to the extratissual space, right? The outside space of the tissue, it's moving there, due to which the oncotic pressure has changed, right? Oncotic pressure. There is no change in osmotic, but oncotic pressure. The protein levels in the blood have decreased, due to which they're all moving, all the fluids are moving out. Then we can say it is an edema. And how do we identify it's an edema? If we press on that, we can see a bumpy surface going in, and it stays for some time and then comes back. That is an edema, right? And inflammation is something different. It is due to a hyperactive immune system. Next can be tuberculosis. Then is hydropneumothorax. This is together called as compressive atelectasis, hydropneumothorax, and along with this certain tumors also which compress, right? Next can be narrowing of small bronchi due to spasm or bronchitis. Again, due to a spasm or bronchitis, that is again inflammation of the bronchus or block of alveoli, right? Next is shallow respiration in case of acute pain of muscles. So if there is painful breathing, right? Suppose you had a trauma of the ribs, then it can also be seen in that case. In case of dry pleura, acute mastocytosis, intercostal neuralgia, right? Intercostal neuralgia. Again, that is related with the neurological conditions. Rib fracture, elevated abdomen pressure, high diaphragmatic level. In case of such diseases, it can be seen. We can see tachypnea, right? Tachypnea. Physiological condition is when you've done a physical exercise. That is normal physiology, right? You are breathing. But these are the pathological conditions. Next, we will discuss about bradypnea. That is slow breathing rate. So, if tachypnea was breathing rate greater than 20 per minute, so the normal breathing rate is what, 16 to 20. But for the tachypnea it is greater than 20, then definitely bradypnea is less than 16. If the breathing rate is less than 16, then we have bradypnea, right? And the graph is just very different for this. I will draw it for you and I'll show it to you guys. So let's continue with bradypnea. As I told you, if the respiration rate is less than 16 per minute. So why is this caused, right? So physiologically, if you see, if you're under the state of rest when you're sleeping, definitely your respiration rate tends to go down, but that is physiological, right? But if we see the pathology, then this may be secondary to increased intracranial pressure. So if the intracranial pressure is increased, then we can see bradypnea. So what are the cases, right? Your cerebral tumor, hemorrhages, meningitis, and edema of the brain, right? So wherever the intracranial pressure is increased, right? So what will happen is the respiratory center is triggered in such cases, so due to which we can see bradypnea or slow breathing rate. And also in case of toxic effect of uremia. What is uremia? Presence of urine in the blood, right? Presence of urine in the blood. Please don't confuse it with blood in urine, right? That's not this. This is uremia. That is blood. The urine is present inside the blood, right? In case of diabetic and hepatic coma. Then in case of drug-induced respiratory depression. So what is a drug-induced respiratory depression? So whenever suppose a procedure has to take place, suppose we go for a bronchoscopy, we have to take this inside. So what happens is we give certain anesthesia. What they do is they decrease the respiratory rate so that there is no disturbance while the procedure is being taking place or whatever it is. So anesthesia is the best example of drug-induced respiratory depression. Next, let's talk about respiratory depth, right? Respiratory depth. The volume of inhaled plus exhaled air at rest. So it is 300 to 900 ml, 500 ml for an average. So based on respiratory depth, we can divide it into two parts, that is shallow respiration and deep respiration. So shallow respiration is short inspiration by expiration phase. Breathing is rapid. In some cases can be slow due to inhibition of the respiratory center, as I told you in case of meningitis, cerebral edema, or in case of hemorrhage or cerebral tumors, right? So over there what can happen is shallow and slow breathing rate is seen, right? And also in certain cases of emphysema, where the surface area is decreased, sharp narrowing of the vocal slit or trachea, right? So sharp narrowing of the vocal slit, if the lumen itself is narrowed, then again yes, we can see this also. In case of deep respiration, now deep respiration, what is this? Elongation of inspiration and expiration. Rapid deep breathing causes, what are the causes? So physiologically, if I say it is exercise, right? Other than that, if it is pathological, it can be anxiety, fever, anemia, metabolic acidosis. So one very interesting thing about deep respiration is this is seen in coma patients, right? Now why in coma patients? So what happens in coma patient? The patient is always bedridden, right? Due to which the muscles are always in contracted state. There is no much movement in the muscle. So what happens is muscle continues to accumulate lactic acid. More and more lactic acid is being accumulated, due to which what happens? Metabolic acidosis is taking place and not gaseous acidosis or respiratory acidosis, right? There is no respiratory acidosis, but whereas there is metabolic acidosis. This is because of poor movement of the limbs, due to which lactic acid is being accumulated. This is metabolic acidosis. But in case of respiratory acidosis, it is a different case wherein it is breathing, right? So cause of metabolic acidosis can be many reasons. Suppose a patient has vomited a lot, right? So what happens? All the not vomited, but he's lost a lot of body fluids through motion. So what happens? All the base is moved out of his body, due to which acid concentration is increasing. So this leads to, again, this can also be metabolic acidosis. So there are various cases we can discuss. So this is most seen in comatose patient, and this is how it looks, right? So again, a deep rapid breathing with marked respiration movement, and noisy sounds, right? It's called Kussmaul's respiration, and this is how the graph looks on the spirometry. It is hyperpnea, that is more of breathing, and hyperventilation. So the breathing is very fast. So hence you can see these so many graphs at the same time, right? So many question troughs are found over here. So there is hyperventilation. So deep rapid breathing with marked respiratory movement and noisy sound is called Kussmaul's respiration. Now let's come to different various other types of respiratory sounds we can hear. Now some of them are chain stop respiration, Biot's respiration, and various respiration patterns, not sounds, they are respiratory patterns. So we'll discuss what is a chain stop respiration. So it is a noiseless shallow respiration, quickly deepens, becomes noisy to attain a maximum at 5 to 7 inspirations and slows down. Such period alters with apnea, wherein there is absence of breathing, during which patient can lose orientation or faints to recover from unconsciousness after respiration is restored. Now if I tell it to you in simple words, what happens is, initially the respiration is noiseless, there is no noise, right? Then what will happen is the respiration starts to become very deep. Quickly it starts to become deep, and as the respiration becomes deep, it is definitely, if you're breathing deeply, it is noisy, right? So it attains up to 5 to 7 inspirations. So for 5 to 7 inspirations out of those 16 to 20 inspirations and expirations, so those 5 to 7 inspirations are quickly deepened, right? And then it alters with apnea. What happens is after some time, apnea is going to take place, that is complete absence of respiration. So at this phase, the patient can lose consciousness, he can faint, and then he will recover once the respiration is being restored, right? So we can see this in children, aged people show this during their sleep. It is seen in sleep, and in other pathological conditions such as heart failure, uremia again, right? Presence of urine in the blood. Then drug-induced respiratory depressions, such as, again I told you, anesthesias, and brain damage such as a cerebral stroke or acute and chronic disruption in the circulation of the supply to the brain. In case of cerebral hypoxia, when the brain is receiving less oxygen, and in case of meningitis. So this is the graph. What happens is initially it is normal, becomes rapid for 5 to 7 inspiration, then followed by phase of apnea. This is absence. So on a graph, if I have to draw apnea, what is apnea? Simple line. If in case of ECG also, if a person heart is not beating, how is the ECG? It's a straight line. So similarly, apnea is also a straight line, followed by the phase of apnea and restoration of breathing, wherein he can get back his consciousness, right? Next we will discuss what glucose respiration, is, and then we will come to what is Biot's respiration. So now we have come to the last two parts of the respiratory patterns. So one of them is glucose respiration. So what it says, it resembles change stalk, but the phase of apnea is replaced with shallow breathing. So as I told you, initially it is a noiseless breathing in change stalk, but there is a period for 5 to 7 inspiration. The breathing becomes deep, and also it is very fast, right? It is fast, noisy, and deep. So same thing is happening here, but the apnea, the phase of apnea which is present in change stalk, is replaced with shallow breathing, right? So we can see the small graphs over here. So there's shallow breathing over here. That is basically the glucose respiration. It's similar to change stalk, except the phase of apnea is replaced with shallow breathing. So what are the causes? It is caused by the primary stages which lead to change stalk, which is heart failure, disruption in cerebral circulation, meningitis, stroke, or hemorrhages. So before change stalk we can see glucose, and after glucose we can see change stalk, right? Next is Biot's respiration. So what happens over here is deep rhythmic respiration alters with apnea. So deep rhythmic, the breathing is completely in rhythm, right? It is normal in rhythm, but it is with apnea for a few minutes to 30 seconds. So the causes are respiratory depression, brain damage, and agony, which involves the disorder of cerebral circulation. So the death which is caused due to disruption of cerebral circulation. So we can see Biot's respiration. So what it shows, this is normal rhythmic with the phase of apnea, rhythmic apnea, right? So this is how Biot's respiration is summarized. So with this we have discussed about various breathing patterns, and in the next lecture probably we'll discuss about the methods of examination of the chest, percussions, auscultations, and various other features. And if you like the video, do subscribe to my channel, and thanks for watching.